Candice Silverman. You've seen my video on an overview of obesity and obesity being a chronic disease. I'm now going to talk about the gastric bypass. The gastric bypass is considered by many to be the gold standard weight loss operation. It's been around for a long time, over 20 years. It was first done as an open operation, and in more recent times it's done laparoscopically. I do it laparoscopically, 5 small incisions while the patient is asleep, i.e. you're having a general anaesthetic. The gastric bypass is indicated for patients that fit the usual recommendations for a weight loss operation, i.e. BMI over 40 or BMI over 35 plus with weight-related health conditions. If a patient wants a gastric bypass and they fit those criteria, I think it's a more than reasonable operation to have. Where, say, I would choose a gastric bypass over a sleeve gastrectomy for my patients are really for 3 reasons. Firstly, for reflux. So if a patient has considerable reflux symptoms, I think the bypass is a better operation than the sleeve gastrectomy because it really decreases any acid that is sent up into the esophagus, and I'll explain how this works. So really the gastric bypass, as well as being considered the gold standard weight loss operation, is also a gold standard anti-reflux operation. And how this works to improve reflux symptoms, if we're talking about this alone, is 2 ways. So one, and I've drawn what's involved with a gastric bypass here. So it is done keyhole surgery. The first part of the operation is to partition off a small portion of the stomach from the rest of the stomach. And it's the rest of the stomach, it's this portion of the stomach that actually makes the acid. So after portioning off the top portion of the stomach, I divide the small bowel and then reroute the small bowel to join at the top of the new gastric pouch. So this contents in here, if you eat and it comes down into the small bowel, it's less likely for you to get reflux. And also the products in here are they're not acid. So if you do get any regurgitation, it's not acid. So in that way, the gastric bypass is actually also a very good anti-reflux operation. As well as being a good anti-reflux operation, it probably has a greater anti-diabetic effect than the sleeve gastrectomy and also the gastric band. The sleeve gastrectomy does have an anti-diabetic effect beyond weight loss alone, but the gastric bypass's anti-diabetic effect actually exceeds one of the sleeve. So say for patients that have type 2 diabetes but also are also requiring insulin, I think a gastric bypass is a better operation for them. The other time I choose a gastric bypass over, say, the sleeve gastrectomy is for those patients that have had previous gastric surgery or previous weight loss surgery. And this might include previous surgery for reflux, i.e. fundoplication, might include previous weight loss operations such as a gastric band or the old weight loss procedure called the vertical banded gastroplasty or the old gastric stapling procedure. And the reason for this, as opposed to the sleeve gastrectomy, is that if we do get any leaks from this top part of the stomach and the top joint, they can actually be managed quite easily and safely in hospital without spending a long period in hospital as would a leak for a sleeve gastrectomy. So if you get a leak after a gastric bypass, if it's related to this top part of the operation, you're less likely to need a long time in hospital as if you would if you had a leak from a sleeve gastrectomy. So again, to explain the operation, I first make a pouch in the top part of the stomach. I then divide the small bowel. I bring it up, make an anastomosis between the stomach and the small bowel, and then again another anastomosis between the divided small bowel and to the new alimentary limb. So how the bypass works, well, 2 ways. One, you can fit only a smaller amount of food in there, so restriction. 2, because it's this part of the bowel that receives bile and pancreas juice, and that now enters a little bit lower into the small bowel. Now, we haven't quite figured out the actual molecule or the group of molecules that achieve this, but by bypassing that small segment of bowel, we actually find there is improvement in diabetic control and also the hormones that are involved with appetite and metabolism. The bypass also has what's called a hindgut effect. So carbohydrates actually make their way to the end of the small bowel quicker than normal, which again causes the release of insulin-like peptides, which causes an improvement in blood sugar control. Another benefit of the bypass, and it's actually something you need to appreciate if you do have a bypass, is a concept called dumping. Now, what dumping means is that if you have a very sugary drink, such as a chocolate milk, if you drink chocolate milk, the chocolate milk in here goes straight or dumps straight into this small bowel. So that the sugar particles in the small bowel do 2 things. 1, causes the influx of fluid via an osmotic effect, and 2, down the track, so later, maybe about an hour later, will cause an increase in insulin levels and then a rebound hypoglycemia. So the concept of early dumping is you have a sugary drink, you get a queasy feeling in your stomach, and then you might have some diarrhea. Late dumping is where you have the sugary drink and about an hour later you might feel faint or sweaty from having low blood glucose. But really, if you consider why you've had the operation, i.e. it's a weight loss operation, and really we need to be avoiding simple carbohydrates such as sugary drinks, so it is in a way forced behaviour modification from having this effect. So they're the ways that gastric bypass causes weight loss. When you compare sort of weight loss results from the gastric bypass to the sleeve, they're pretty similar. The gastric bypass results probably a little bit more weight loss than the sleeve gastrectomy, but both of them I'm assuming will have that element of weight regain. And certainly the gastric bypass, we've got a lot of data from the weight loss results at 10 years and 20 years, unlike the sleeve gastrectomy where perhaps we only have the data to 5 to 10 years. So the bypass does remain as the most commonly performed weight loss operation in the world, and we've got the best long-term results for it. In terms of downside for the bypass, I guess it's a little bit more complex. It has the risk in hospital that you'd see with any keyhole operation, i.e. risks of bleeding, damage to other organs, but on top of that you also have the risk of leak or non-healing of these joins. So the leaks can occur anywhere that there's a staple line or a join. If there is a leak from the top part of the abdomen, patients might have more pain than is expected, their heart rate might go up, they might have some difficulty breathing. We'll generally diagnose it with a CT scan. The next step often involves surgery, again keyhole surgery, to remove any contamination and place a drain. With the bypass operation, if you do have a complication such as this, normally patients would only spend about an extra week in hospital. Fortunately, these complications don't happen commonly. It's about a 1 or 2%er, so that's the early complications from a gastric bypass. Down the track, there is the long-term risk of getting a bowel obstruction, and that's because we've divided the bowel here, so it is possible for the bowel to kink. The risk of this happening long-term is around 5%, but it does mean that you have a rerouting of your bowel, and if you have any issues with abdominal pain or vomiting, you do need to present to hospital early. And if you present to hospital, you need to let the surgeons there know that you've had a previous gastric bypass, or ideally contact me so I can help you. But for me, another advantage of the bypass operation, not that you want it reversed, but we haven't removed any of your organs. Everything can still be intact, and if necessarily, this operation is potentially reversible. It does have some benefits over the sleeve, and they mainly relate to the additional anti-diabetic control. Also, we know the long-term weight loss results, and perhaps it may be a safer operation, say for someone that's had a significant complication following a gastric band or from previous gastric stapling.